I was just actually
Yeah,
start.
he said he's okay.
I was just actually
Yeah,
start.
he said he's okay.
I was just actually
Yeah,
start.
he said he's okay.
I was just actually
Yeah, he said he's okay.
Good morning, everyone. We are going to start our eighth symposium in pediatrics today. I mean, that's quite an achievement because every symposium, we used to actually have around 4 to 5 topics, but with time, we decided that it's better to actually have a less number of topics so that we have time for presentations, discussions. And so today we are just going to keep 3 excellent topics. We got some excellent speakers. And I will now hand over in a minute. Oh, sorry, it's still got 10 more minutes to actually go. I thought it was just, I got it wrong. We are early, but anyway, we will actually start off in a sense. We won't start the discussions, but we can actually start with Jory actually telling about something about our symposiums, about our faculties that we have had and our experience till now, because this is the 8th one. So over to you, Jory. Your mic is still off. Yeah, Jody, you're on. Yeah.
Okay.
Yeah.
I hope.
I think before we start off that, you can actually tell a little bit of journey of all the pediatric symposium we've done. This is the 8th one. We still got time.
Thanks, Shiv, for giving us a forum to present our pediatric topics. Obviously, we started quite in the just before the start of pandemic, right? So it's been a journey that's been sort of we had a lot of support, energy, enthusiasm to go through this, and then suddenly the COVID came and hit. And then there was a time when we were feeling, like what is the right thing to do, and but that thirst for knowledge and sharing of knowledge has been always there, and we are able to keep up the momentum. So we are on our 8th one. In the beginning, we planned out what key topics we want to talk about in this that will be of interest both to a general anesthesiologist who are dealing with children in their practice, as well as to the trainees. We also wanted to take up some of the interesting areas, the challenging areas in pediatric anesthesia, so that it's more of an inspiration for people to take a journey if they want to do pediatric anesthesia as a main career choice. they can see the breadth of the specialties and get interested and take it on. So that was our sort of a theme of the topics we chosen. So we wanted to make sure that over this journey we cover the key areas that's important in both for exam purposes as well as for everyday practice. So that's been the case. We probably will, looking at the syllabus, we may have another 3 or 4 symposium days. That will take us to 11, 12 symposiums and 36 to 40 topics in total. So that'd be a great resource for people to look back, because it's all stored, archived in our Facebook. If people, even if they want to review something, they can quickly go back, whether they want it for their own practice or to teach the trainees. It's available to them. And this has also fostered quite a bit of international collaborations for learning and teaching amongst various people. So it has been really, I would say, a happy experience for me to connect with many of our speakers present today, as well as who are present at the talks, to get to know them, not only as the distant colleagues, now as friends. So it's been a great journey for me. I thoroughly enjoyed it, and I should thank you for giving this opportunity for me.
It's not me. We already actually had a platform. We're just using it as to promote education. And what we believe in, that education should be free. It should be, all the faculty have actually joined, voluntarily. It's not something which we actually had to force somebody say, oh, I want to do it because I am so and so. Everybody has joined on their own. They give their own time, and they are actually, like, for example, today is a weekend, and people actually have given their own time for promoting education. And I think that is the biggest selling point for these kind of activities. We're not promoting anything. We're not actually, forcing anyone or anything. Everybody actually does. Everybody enjoys it. And I think that's how education should be. Everybody should actually enjoy what actually they are doing. And the next, I think, the natural kind of progression to this, what I was actually talking to you before, Jordi, is to actually have a kind of a half, 2 half days or a day long symposium on some of the essential topics which actually are important, or maybe like they are scoring topics for trainees, as well as topics that could be useful for occasional pediatric anesthetists or people in freelancing. So that, I think, would be actually a good one. And we can always get, again, I can try for Royal College CPD approval. And if it is going to be 2 half days, then we can get 5 and 5, 10 CPD points, which is actually pretty good. I think they give you from 8 to 10 CPD points. So we actually have that channel open with the Royal College of Anesthetists. So it's a useful thing. So all the faculty, please think about the topics, think about, from your friends who occasionally do pediatrics and things, from basics to some of the practical stuff. I think that would be useful. And I think Christmas and holidays are approaching. I don't know when, Jordi, you're planning the next one. So I think we need to actually think about that. So do we start from the New Year's onwards, or we actually have another one you want to do?
What's the November end like? Is there any holidays around that time?
November end, I'm probably in India at that time, but you guys can do it. You can set it up and do it. It's not a problem at all.
I'll reach out to the faculties and see who are all available.
Yeah. because I think it starts getting a bit busy during this time, and I think we don't know how things are going to progress, but yes, we can. But if not, then we can obviously start off in the New Year's time and start off from the 9th topic itself.
Sure.
So where are we time now? I can't see the time on my clock.
7:58. We have another couple of minutes.
Nearly a minute to actually, to start off.
Yeah, Dave is joining in a couple of minutes as well.
Yeah, absolutely. So Dave is already, he's a expert, so we don't have to actually. He's been to quite a few of our symposiums. I mean, he's been a very useful. I won't say useful, but great faculty for us. Useful is it's like saying as if we're using him, but it's no, he's actually absolutely a great faculty, I think, and he's taken some great topics. Kalyani has been with us. Vikram has been with us. I think Parin, you're joining for the first time on the symposiums.
He has done it. Parin has done another one.
Initially, I think very in the beginning. So that's that. I will also be again in March. Would be planning the crisis symposium again. So that is going to be now the yearly thing. I don't know any of you. Vikram, you were there part of the crisis symposium, isn't it? Kalyani, did you do any of the topics? No, you didn't. Parin didn't, I think, either. So it's a 2 days symposium, 2 half-day symposium. We get 8 CPD point credits from the Royal College. So we do it. The first one we did last year in March. So we plan to actually, this year in March, and we plan to next year as well in March. We'll make it as a regular recurring thing. So that's something else to look forward to. It's a I think very nice symposium with kind of topics. Essentially, so it has all pediatric, cardiac, general topics. So it's got all the aspects of it.
I think we can go ahead.
So shall we start today's symposium then?
8
okay.
o'clock.
Over to you, Jolly. Yeah.
Okay. All right. Greetings, everyone, and thanks for joining our 8th Pediatric Symposium, where we discuss the key topics of interest for the anesthesia trainings and practicing pediatric anesthesiologists, the general anesthesia with pediatric interest. And some of the topics we chose for today's discussions are very crucial because all these 3 very likely can appear in any residency exam, anesthesia exam. But it's also important for your day-to-day practice, as you said. So we have lined up 3 key speakers. The first topic will be on Tracheology of Fallow, presented by Dr. Parin Shalani, and it will be moderated by Dr. Vikram. Dr. Parin Shalani is an assistant professor in anesthesia from All India Institute, New Delhi. Her main interest includes airway management and pediatric anesthesia. This is our second presentation for our Facebook teaching group, and I thank Parin for volunteering to take up this topic, and we very much look forward to hearing from you on this one of the key topics, exam topic. And I want to specifically thank Dr. Vikram for moderating this session. Many of you know Vikram from as a pediatric cardiac anesthesiologist. He's a very active Facebook member. He contributes widely, giving his in-depth experience in management of complex pediatric cardiac cases. He's widely published. He's author of many articles. He's also a reviewer of many journals, specifically in the pediatric cardiac world. So it's my pleasure to welcome Vikram to moderate this session. We will follow that with Dr. Dave Chatterjee's talk on mediastinal mass. If people, I have to be honest, when I started my anesthesia journey, or even when I finished my MD anesthesia, I didn't know very much about mediastinal mass and its implications and stuff. And in fact, one of the faculty at the time who was visiting from Australia quizzed us, and we miserably failed in just giving the standard routine rocuronium anesthesia. And he said, if you would fail this in a Royal College exam, that prompted me to look back and learn a lot. And then over the past 10, 15 years, one of the scariest thing in pediatric anesthesia is managing a patient with a mediastinal, especially the smaller they are and bigger the tumor is. This is probably as close to like a severe pulmonary hypertension patient we deal with. So it's one of the top nightmare scenarios for anesthesiologists. So very much look forward to hear what Dr. Dave Chatterjee has to say about this and how we safely manage these patients. Dave is a well-known world in the pediatric anesthesia faculties, well-known name, I mean. If you haven't listened to his Open Anesthesia podcast, he's a co-editor of that. And it's a great resource for the trainees, and I regularly listen to it. And I really thank Dave for sparing his time, in spite of his busy schedule, to talk to us. So thanks, Dave. And the third topic will be on pediatric life support, resuscitation and life support. And I thank Dr. Kalyani to take up this topic. She did a wonderful talk with us on the neonatal resuscitation. It is one of those things, is such a vast area to cover in the 30 minutes. I'm really glad Dr. Kalyani volunteered to take this on. And we very much look forward to hearing the advances in the resuscitation world and some of the key underlying principles. Yeah, that'll be great. So without wasting much time, I would invite Dr. Pareen to start her talk. I'm just going to stop sharing my slides.
So should I share my screen?
Just one second.
You can now,
Okay.
Pareen. Yeah.
Yeah.
Is it visible, sir?
Yeah.
Thank you. Hello, everyone. Thank you, Shiv sir, Jadi sir, and Vikram sir for providing me this opportunity to share this platform once again with all of you. The topic of my today's presentation is anesthetic management of a child with TOF for drainage of brain abscess. It is one of the very challenging clinical scenarios. And before providing anesthesia in these patients, it is really very important to understand the pathophysiology of both these conditions, and as well as to learn how these conditions are affecting each other and precipitating each other. So first of all, let's see the components of TOF, and then we will discuss their pathophysiology one by one. So TOF, it comprises of right ventricular outflow obstruction, ventricular septal defect, an abnormally placed aortic wall about the ventricular septum, that is called overriding of aorta, and then there is a right ventricular hypertrophy. The key feature of the TOF is this right ventricular outflow obstruction, and most of the times it is because of the hypertrophy of the infundibular muscles, which causes dynamic infundibular spasm. And since it is dynamic, So it can be aggravated, and as such, there are certain factors which may relieve this spasm. And in the 10% of the cases, it is the obstruction is at the level of the pulmonary wall, and in another 10% of the cases, it is below the level of the pulmonary wall. So let us see this picture. Here, the blood comes from the superior vena cava and inferior vena cava from right atrium to the right ventricle, right? And then from here, the blood must enter in the pulmonary arteries, but since there is obstruction, so a certain amount of blood is able to enter in the pulmonary circulation, and the rest of the blood is pumped into this from this ventricular septal defect into the left ventricle. But this blood is deoxygenated, and then this deoxygenated blood is pumped into the aorta, and then finally into the systemic circulation and in the brain. So the TOF has various effects, and one of the very dreaded effect is cyanotic spells. As I have mentioned that the infundibular spasm is dynamic in nature. So whenever it is triggered, the patient lands up with cyanotic spells, and the deoxygenated blood, as it is being circulated, the patients have in a state of chronic hypoxemia, and the saturation of these patients is frequently found in the range of 80 to 85%, and if the severity is more, then it may be less than 85% also. These patients frequently have conduction blocks, and these are of ventricular or supraventricular in nature. Later on in the disease, because of this right ventricular hypertrophy, the ventricular relaxation decreases, and there is diastolic dysfunction, and along with the arrhythmias, these patients may have congestive heart failure also. Then the chronic hypoxemia, it stimulates the production of the erythropoietin, and for the better oxygenation of the tissues, the response of the body is polycythemia. And so the polycythemia, these patients have frequently have polycythemia, and the hematocrit count is more than 65%. And this polycythemia has various systemic effects, and may also lead to various type of coagulation problems. And so first of all, here we will discuss the most dreaded complication, that is the TEC spell. Before anesthetizing these patients, we must know what are the triggering factors and what are the relieving factors, how we should treat cyanotic spells before anesthesia, and what are the manifestations during anesthesia, and how we should treat under anesthesia these patients. So the cyanotic spells is the recurring bouts of severe cyanosis and hypoxemia. There is acute reduction in pulmonary blood flow caused by a sudden increase in right to left shunt, secondary to infundibular spasm, or alteration of systemic vascular resistance to the pulmonary vascular resistance ratio. Since if the systemic vascular resistance will be high, the blood will be shifted from the left ventricle to, if the systemic vascular resistance is low, the blood from the right ventricle will be shifted to the left ventricle, and it will not be oxygenated, and it will further precipitate the cyanotic spell. So the triggering factors are the infundibular spasm is frequently triggered by the sympathetic stimulation, which may be caused by pain, crying, fright, or agitation. Other factors like hypoxia, hypercarbia, acidosis also precipitates infundibular spasm. Vasodilators and hypovolemia, they leads to reduction of systemic vascular resistance. Now here we can see that both these factors may increase the right to left shunt. It means blood is getting deoxygenated, and there is increasing hypoxia, and increasing the ventilation is also poor, since the blood is not entering into the lungs. So it will increase PaCO2, and it will cause increasing acidosis. Both these factors, as we all know, precipitates increase in pulmonary vascular resistance, and it will further increase right to left shunt. This increase in pulmonary vascular resistance will increase, the patient will have increased respiratory efforts. He will feel tachypnea, and then this increased respiratory efforts will lead to increased systemic venous return, and it will further lead to right to left shunt, and thus it is a vicious cycle. It will manifest as abrupt worsening of cyanosis, and there will be tachycardia, further hypertension, tachypnea, and it ultimately it can lead to, because of hypoxia, patient may have convulsions, syncope, sometimes stroke, and even if it get worsens, death may also occur in these patients. So the treatment is, we can find these patients spontaneously acquiring squatting position, also known as knee chest position. So the treatment is, we should give sedation as in the form of morphine, 0.1 to 0.2 milligram per kg can be given intramuscular. Ketamine can also be used in the doses of 1 to 3 milligram per kg. Intramuscular doses can be used. Morphine decreases the air hunger and it will reduce tachypnea. Phenylephrine in the dose of 0.1 milligram per kg intravenously or 0.1 to 0.5 microgram per kg per minute in the infusion form will increase the systemic vascular resistance and will decrease the heart rate and will help in decreasing the infundibular spasm. Propranolol also in the dose of 0.05 to 0.25 milligram per kg will decrease the heart rate and will decrease the infundibular spasm. Soda bicarb will help in reducing the metabolic acidosis, and then oxygenation 100% can be given, and rapid IV fluids in the dose of 20 to 25 ml per kg can be given fast to relieve the infundibular spasm. Then if it is not relieved, controlled ventilation, and even if it is not relieved by the drugs and all these maneuvers, emergency palliative Blalock toxic shunt surgery may also be required in these patients. Now, these patients are generally very malnourished and have very poor immunity because of the persistent and chronic hypoxemia. They are in a state of persistent breathlessness and tiredness, and this weak immunity, because of this they have they cannot feed properly, and they have these poor immunity may lead to chest infections, fever, growth retardation, delayed milestones, severe metabolic derailments, and even multi-organ failure. TOF can account for 13 to 70% of all brain abscess. And how does it causes the brain abscess? One of the mechanisms is by the polycythemia, which leads to sluggish blood flow and cause cerebral infarcts. And the second factor is poor host immunity, and lung is a very good filter. It has phagocytes, but this because of the tetralogy of the fallow, the lung is bypassed. All these factors ultimately may lead to frequent brain abscess in these patients. Then these patients have very fragile cardiopulmonary status, as I have already discussed, that they may have frequent arrhythmias, ventricular, supraventricular, various types of heart block, congestive heart failure, and they are very prone for infective endocarditis. And all these factors may cause severe hemodynamic instability in these patients. And polycythemia may leads to various type of coagulation abnormalities, and there is a deficiency of vitamin K dependent clotting factors in these patients. There is a thrombocytopenia, and the function of the platelet is also defective. There is accelerated fibrinolysis, which may cause abnormal hemostasis with frequent and increased bleeding. Now let us see how does the brain abscess further worsens the situation. So the brain abscess, it leads to, since brain is a tight compartment, it has three basic components. First is CSF, second is brain matter, and the third is blood volume. If any other space occupying lesion is there, then it is definitely causing rise in ICP. And rise in ICP manifest as nausea and vomiting. These patients may have poor GCS and may have poor oral intake, and it will further reduce and it may cause dehydration. And if ICP is increased to uncontrollable levels, it may lead to coning and even death in these patients. Then this brain abscess may cause locally brain irritation, which may cause seizures and meningitis. Then various type of diuretics are being used in these patients to decrease the ICP, like mannitol and furosemide, which may cause dehydration and electrolyte imbalance. Now it is very interesting to see that how these both conditions are precipitating each other. So let us see this, that the TET spell caused by tetralogy of Fallot and the further hypoxia, hypercapnia, and metabolic acidosis. All these factors are responsible for increasing ICP in these patients. And the increase in ICP causes nausea, vomiting, dehydration, and which further increase the hyperviscosity. All these factors, as I have discussed, the dehydration, hyperviscosity, all these factors may precipitate TOF. So the aim of our anesthesia, it should be like that we should maintain a balance between both these pathophysiologies so that they may not precipitate each other. In these patients, antibiotics are being frequently given, and some of the brain abscess which are at the surface, local anesthesia can also be given, and is frequently being used for the aspiration of brain abscess. But then the local anesthesia may increase the pain, agitation, and may further precipitate TOF. So general anesthesia is with controlled ventilation has its own benefits and is preferred in these scenarios, like if the child is small, uncooperative, there is very high ICP, the child is throwing seizures, there is congestive cardiac failure or hemodynamic instability, or there are history of frequent cyanotic spells. Now, the goals of our anesthesia should be like that we should be able to prevent rise in ICP, and we should be able to provide a relaxed brain so that surgeon may have an easy access to the brain abscess. Then the most important thing is we should be able to maintain adequate cerebral perfusion pressure, which is mean arterial pressure minus increased intracranial pressure. So mean arterial pressure and intracranial pressure has to be maintained. Then we should try to prevent cyanotic spell and prevent further increase in right to left shunt, maintain higher systemic vascular resistance relative to pulmonary vascular resistance, then maintain oxygenation and hydration. In the pre-anesthesia checkup, document the current cardiac and neurological status. What is the GCS of the patient? What is if the child is if the child is in any cyanotic spell, and look for the associated complications and syndromes. Like there are various syndromes which are associated with the TOF, like Digeorge syndrome, Vector syndrome. These are associated with frequent airway problems like macrognathia, large tongue, and look for if the patient is having prior abscess surgeries or had palliative cardiac shunt surgeries. Then what are the current medications of the patient? Anti-seizure prophylaxis, diuretics, beta blockers like propranolol, and assess for coagulation profile, and get a cardiology consultation and get a 2D echocardiography done to see the severity of the right ventricular outflow tract obstruction, the level of the stenosis, the intracardiac anatomy, associated congenital defects, and coronary anatomy. In the pre-operative preparation, ensure that these children are not fasted for prolonged periods. The clear fluid should be allowed until 2 hours before surgery. And if diuretics are being given, use them cautiously. And if the child is severely cyanotic with a hematocrit of more than 60%, then preoperative phlebotomy may be considered after consultation with hematologist, and give a good and effective endocarditis prophylaxis. Then preoperative medication may be given in the form of 0.5 milligram of midazolam 30 minutes in 5% dextrose 5 ml 30 minutes before surgery, so that the patient may sleep and apply oxygen mask. And then one should prefer a gentle separation of the child from the parents and avoid any unnecessary breaks and prevent crying and precipitation, and thus finally the precipitation of cyanotic spells. Then in the induction can be done by IV induction, or if the child does not have any IV line and is not cooperative, then inhalational induction with sevoflurane can also be done in these patients. IV induction, since the drugs are not passing through the pulmonary circulation, the effect attained is more as they are directly entering in the systemic circulation and reaching the brain. So these IV induction drugs should be given slowly. And drugs like thiopenton can be used, but has to be given slowly and in a lesser dose. And thiopenton it decreases the cerebral oxygen demand, and as well as it decreases the cerebral blood flow, and it has anti-seizure properties. So, but it may cause sudden hypotension if it is given faster. So it should be given very slowly and in a reduced dose. And then etomidate, as we all know, it has a good hemodynamic effects, and as well as the effects on the brain are also the effect on the brain. It does not cause any increase in ICP, so it is also a very good drug in these patients. Ketamine is an ideal drug in TOF patients as it increases SVR, but in this case, it may increase the intracranial pressure. So in these type of patients, it should be avoided. Then many people use high opioids with low benzodiazepine, as opioids have a very good hemodynamic effects. They don't aggravate any hypertension or bradycardia. They have generally very good hemodynamic effects. So, but the disadvantage is that if the duration of the surgery is short and one wants to assess the neurological assessment post-operatively, so the awakening may be delayed and patient may need prolonged mechanical ventilation if you are using high opioids. And the other advantage of, but the advantage of the opioid on the, as I have said, it does not perturbate the hemodynamic situation, and the effect on the brain is also minimal. That is, it does not increase any cerebral blood flow, it does not increase ICT. So in that way, it is good. But on the other hand, it prolongs the duration of the mechanical ventilation. Then induction can be done with inhalational agents like sevoflurane. It has sweet smell. In TOF patients, halothane is a good agent as it decreases the infundibular spasm. But in these patients, the halothane, it increases the cerebral blood flow. And although it decreases the CMRO2, but it increases the cerebral blood flow. So it increases the ICP. And it also causes myocardial depression and cause various type of arrhythmia. So it should be avoided in these patients of with brain abscess. And sevoflurane and isoflurane, both can be used for maintenance, but the MAC should be kept below 1 MAC. As above 1 MAC, these agents may increase cerebral blood flow and may increase ICP. And below 1 MAC, they will reduce CMRO2 and will not increase cerebral blood flow, will prevent cerebral vasodilation, and will prevent also excessive myocardial depression and right ventricular failure. So these agents should be used in less than 1 MAC. Nitrous oxide, it increases pulmonary vascular resistance and it increases systemic vascular resistance. It also increases cerebral metabolic oxygen demand. So it should be avoided in these cases, and if it is used, it should be restricted to only 50%. Then many anesthesiologists nowadays are using dexmedetomidine because since it blunts the sympathetic response to intubation and reduces the opioid and volatile agent requirement. And it is also good for neurosurgical patients as it do not increase ICP. These patients should be put on controlled ventilation, and our target should be to avoid hyperventilation and to avoid PEEP, as increase in PEEP will cause increase in SVR. Then pulse oximetry is less accurate if the patient is severely cyanosed. So ABG monitoring becomes essential in these patients. Allowable blood loss is more in patients with congenital cyanotic heart disease due to pre-existing polycythemia, and transfusion should be deferred till the blood loss is more than 25% of the blood volume. One of the very important precaution is prevent air entry into the veins as it may lead to life-threatening paradoxical embolism. Since the lung filter is bypassed, so it will directly enter into the systemic circulation and will directly enter into the brain. And to avoid this, use air filters can be used in IV lines. Then avoid hypotension, as it will cause a decrease in SVR. Avoid hypovolemia. Avoid acidosis, hypoxia, hypercarbia, as all these factors will increase the hypercarbia and will ultimately increase the intra-shunting. So let us see how a cyanotic spell may present under anesthesia and how we should treat it. There may be rapidly falling saturation in response to surgical stimulation or other stimulation, and there may be sudden hypotension and ECG changes of ischemia. And if possible, remove any precipitant cause if it is known. Then do this knee chest flexion position as shown in this picture. Then provide high flow oxygen or 100% oxygen, which may improve saturation if once the shunt fraction is reduced. But it helps only when the pulmonary vascular resistance is decreased and the blood is able to reach the pulmonary circulation. Then titrated sedation and analgesia should be given to deepen the plane of anesthesia with the help of morphine, fentanyl, or even ketamine can also be used, but not in these cases as it is a case of brain abscess. Then I have, as already discussed, that fluid boluses can be given to improve the right ventricular filling in the dose of 20 to 25 ml per kg in a minute. And then SVR should be increased with the help of drugs like phenylephrine and noradrenaline or even vasopressin. Then avoid drugs like beta agonist sympathomimetics like dopamine and adrenaline, as they will cause tachycardia and will worsen the infundibular spasm. Adrenaline can be used if there is a profound collapse and if the ventricular function is poor and the coronary perfusion is at risk. Otherwise, it should not be used as it will cause tachycardia, and it also increases ICP by increasing the cerebral blood flow. Then, as we have discussed, that heart rate should be slowed down, so it can be done with the help of esmolol or beta blockers to improve the diastolic filling time. Then in these patients, early extubation should be preferred to prevent further reduction in pulmonary blood flow due to prolonged ventilation. These patients should be observed in the ICU, and appropriate fluid management should be done. Avoid any hypovolemia and hypotension. A good control of pain with the help of paracetamol should be given round the clock, and prevent any vomiting. And anti-seizure prophylaxis should be given. Then these children are at a very high risk of cardiac arrest, and 30-day mortality can be very high in patients below 2 years of age if the surgery is in emergency and the patient is in severe cyanosis with poorly compensated heart failure, and if there are major cardiac anomalies. Then significant higher mortality in congenital cyanotic heart disease patient with during brain aspiration have been found in patients with cyanotic spell, those who have a greater midline shift and those who have cerebral edema. So to conclude, in these patients, carefully administered general anesthesia with controlled ventilation, advanced monitoring, and better preparedness for handling emergencies facilitates a safer environment for maintenance of hemodynamics, oxygenation, intracranial pressure, and seizure control. Thank you.
Stop sharing PowerPoint. Yeah, I think you're trying to do that. It's on the top. You need to go on to the top.
Yes,
Yeah,
sir.
that's it. Yeah. Vikram?
Yeah. Dr. Pareen has elaborated most of the things in a very nice way, and she's covered most of the thing in a very short duration of time. So this is very crisp and covered almost all the points. So as you know, there's a very fine balance when the tetralogy patient comes for a brain abscess surgery, either be it for a Burwell or a craniotomy. So it's a very fine balance where you have to have fasting for the patient and of course avoid dehydration for the patient. So what happens is usually these patients have brain abscess due to microthrombi, which is caused by the microthrombi in these hypocyanotic and higher increased hematocrit patients. So when these patients come for any surgeries like this, they have increased ICP, which is caused by the vomiting, which leads to vomiting or decreased oral intake. All these leads to dehydration. And when we use mannitol or the diuretics like Lasix during the surgery, this again leads to decreased intravascular volume. So there's a very fine balance, and you need to have good adequate intravascular volume during the surgery, which will avoid a hypercyanotic spell. So this is very important, and even the duration of the fasting should be less to around 1 to 2 hours at max, the clear liquids. So that is one regarding the intravascular volume. And most of these patients can be induced with oxygen air. We've almost avoided nitrous oxide from our theaters. So these patients, and of course, if these come for neurosurgery also, there would be for oxygen air mixture as well. So, and thiopentol is almost out of the use now. And propofol we never use in these kind of patients. So it's usually the oxygen air mixture sevoflurane with muscle relaxant and fentanyl around 2 mg per kg. That's what it's done. And hypercyanotic spells. So these patients, any tetralogy patients, it's always a interdynamic play between the systemic vascular resistance and the pulmonary vascular resistance. And of course, the RVOT, that is the right ventricular outflow tract spasm if it happens. So when you increase the intravascular, when you increase the systemic vascular resistance, the pulmonary vascular resistance falls. And it's always the vice versa. So all these maneuvers like pulmonary maneuvers like increasing the PEEP and increased respiratory rate, all these leads to decreased PVR. When there's decreased pulmonary vascular resistance, that leads to increased systemic vascular resistance. So increasing the systemic vascular resistance is the key to managing all these patients. So these can also be done by a pharmacological measure, which is already stated by Pareen before. That is either ketamine, but that's usually avoided in these kind of surgeries. And of course, phenylephrine. Phenylephrine dose, she's already told it's around 0.1 milligrams per kg in as a bolus dose. And other maneuvers like increasing preventing the acidosis with soda bicarbonate, intravascular volume, giving IV fluids, and oxygen also can help if it not the cause of that. So that is regarding that. So as a general anesthesiologist, these are patients could come to us either in a spelling patient where they come to a emergency where it has to be revived and they go to the ICU. So as an anesthesiologist, you face them over there. So you try to treat the TED spill, which has already been told before, how do you treat the TED spill, and then shift them to ICU, and then it's being taken care of by the cardiac anesthesiologist later on for a emergency BT shunt, that is the blow-lock toxic shunt, where you have a shunt, a Gore-Tex graft, which is placed between the pulmonary artery and the aorta. So that is what is the BT shunt. So that is one you either encounter these patients in an emergency or in a cath lab. These patients come to a cath lab procedure before the cardiac surgery to rule out either as a diagnostic or a therapeutic. So these patients come for a diagnostic if we have some doubts regarding the diagnosis. Diagnosis as in these patients sometimes have a coronary artery anomaly. So left anterior descending artery, if it's crossing the right ventricular outflow tract, that is RVOT, that is when we encounter problems during a cardiac surgery. So to rule out that, and if you have any doubts regarding that, these patients come for a cardiac cath procedure. But it's usually obsolete nowadays, but it's sometimes when you have doubts, it does come for that. And to have measurements across the pulmonary arteries, the distal pulmonary arteries and the main pulmonary arteries. And if there are any doubts regarding any additional ventricular septal defects. So when these patients come for a diagnostic, that is one. And if it comes for a therapeutic in the cath lab could be either a RVOT stent, so that antegrade flow across the pulmonary arteries is increased. So RVOT stent is right ventricular outflow tract, where you put a stent across the right ventricular outflow tract and the fibers across that and the pulmonary valve. So that is regarding that. And the third time where these patients come for any procedure is obviously a complete repair for the tetralogy of Fallot. So these are the three conditions where these patients come for when an anesthesiologist encounters these patients. And brain abscess we already discussed as to how it is to be. So there's a very fine balance between these patients coming for a brain abscess. These are usually very sick patients. These have to be, when they come for brain abscess, the acid abnormalities have to be treated, the intravascular volume has to be treated, and these patients, air embolism, you need to be very careful and treat all that. So that is. Any questions?
So there aren't any questions from the audience at all who are watching. So I think it's a very, niche kind of area for, you're talking about cardiac and neuro, that too in a pediatric subgroup of patients. So I think it's something which I think.
Yeah, Parin has covered it very nicely. I mean,
very nicely. I think, yeah. I think Jody actually had raised the issue about the dose of phenylephrine. I think you have corrected that. So I think it's 10 missing. It's 0.01 milligram per kg or 10 microgram per kg bolus, I think, isn't it?
Yeah.
Yes, that's right.
Yeah. Dave, you're highlighted. All of you are highlighted here. Spotlighted, rather.
No, that was an excellent summary. I have nothing to add. Thank you.
Okay, over to you then, Jody.
All right, excellent. Thanks, Parin, and thanks, Vikram. And that was really nice synopsis of a conflicting priorities in a pediatric patient with a tetralogy coming for a brain surgery. Thank you. And hopefully the listeners got to see the challenges and the conflicts in management and the drug choices and the principles involved in taking safe care of these patients. Thank you. And we will move on to our next talk. As I told in my introduction, it's my pleasure to welcome Dr. Devnath Chatterjee to talk to us about anesthetizing a child with a mediastinal mass for a biopsy. Over to you, Dave. Thank you.
All right. Are you able to see my screen?
Yes, we can.
Thank you. Thank you so much for that lovely introduction, Jadi. It's so nice to see all of you here. It's been quite a while since I joined this group. So I'm here today to talk about anesthesia for a child with an anterior mediastinal mass. And what I'm hoping to do over the next 20 minutes or so is tell you how to avoid general anesthesia for a child with an anterior mediastinal mass. So quite contrary to the topic of my presentation. I have no conflicts of interest. I have no financial disclosures related to this talk. And before I go into the details of what the anterior mediastinal mass is and the different, how to manage these patients, I think we can start with some good old anatomy, where we talk about the mediastinum, how it's divided into three compartments: the anterior, the middle, and the posterior mediastinum. I think I want to highlight here is that these are artificial compartments. There's no distinct fascial plane separating these. So any masses in any of these compartments can easily move on and compress structures in the other compartments as well. And if you look at this chest X-ray, it shows you that blue highlighted area is kind of the area that we are focusing on today, the anterior mediastinum, the boundaries of which are the sternum in the front, the thoracic inlet above, the pericardium in the back, and often all the way down to the diaphragm in the bottom. So it's a relatively small space and is usually occupied by contents that typically include the thymus. Usually there's some fat, lymphatics, lymph nodes, and the internal mammary vessels. And so this is a relatively small space, but it can cause a lot of problems. Just a little bit of statistic before we start. Close to half of all mediastinal masses in children are in the anterior mediastinum, and that's what we'll be focusing on today. When you look at the different types of masses, they could either be solid, cystic, or they could have predominantly fatty components. When you look at solid masses, the things that we worry about, which are seen more commonly, are the lymphomas. And then germ cell tumors, probably not as common, and they're usually benign, and they can usually, but it can also cause problems if they are present in the anterior mediastinum. And in the adults, we also worry quite a bit about thymomas. As far as cystic lesions, the most common culprits are lymphatic malformations, and lipoblastomas are the predominant fatty lesions that could be seen in the anterior mediastinum. When you look at the incidence of these tumors, there's a difference between children and adults. In children, most of the times, these are lymphomas and germ cell tumors, and those are the primary culprits, whereas in adults, it's usually the thymomas that are present in the anterior mediastinum. As I mentioned to you before, lymphomas are usually the malignant versions, and germ cell tumors are usually benign. But regardless, both of these lesions can cause a lot of problems when they're present in the anterior mediastinum. Now, I think this is one of the most important slides of my talk, and it talks about the pathophysiology of the anterior mediastinal masses. Now, the primary effects or the primary pathophysiology of the mass in the anterior mediastinum is the compressive effects on the structures of the right heart. That includes not only the right heart, but also the SVC, the pulmonary arteries, and even sometimes the pulmonary veins. And in addition to the compressing the heart structures and the cardiovascular structures, there could also be compression of the trachea and the bronchi. And I'll go into further detail during my talk. And in addition to these compressive effects, there's usually a dynamic component to this compression as well, which is worse in the supine position when the child is laying flat, and that's because of the gravitational effects of the mass actually pushing down on the cardiac structures and the major vessels and the trachea and the bronchi. And in addition to that, there's also the movement of the diaphragm cephalad from being in the supine position. So a combination of the diaphragmatic movement above in the cephalad movement in the supine position, as well as the gravitational effects of the actual mass pushing down on the major vascular structures, leads to major hemodynamic compromise and also compression of the trachea and the bronchi. In addition to this, there's a component of an iatrogenic compression also of the airways when we use the sedation or general anesthesia, or when we initiate positive pressure ventilation. And I'll go over that in a few minutes. Now, going back to the patient with an anterior mediastinal mass, the clinical presentation depends on three major things. What is the size of the lesion, where exactly the lesion is, and how fast it's growing. So obviously, the bigger the lesion, more the problem. And the lesions that are more central tend to cause more problems because you're causing direct tracheobronchial compression. And obviously, faster growing lesions will cause more problems than slow growing benign tumors. Now, when you compare children and adults, which is something that we all like to do as peds anesthesiologists, children tend to have more symptoms compared to adults, because tumors in children, as I mentioned before, lymphomas are more likely to be malignant. Obviously, children have a smaller chest cavity, so there's less room. And as I mentioned to you before, they tend to have more central lesions. They're usually closer to the trachea. And as we all know, the smaller pediatric airways are much more compressible. So as a result of this, children are more likely to have symptoms compared to adults with antemediastinal masses. Regardless, in a certain percentage of these children, they can be completely asymptomatic. And those numbers are different depending on what literature you're looking at. So it's quite a broad range, 20 to 40% is what I have mentioned there. But a big portion of these children can be asymptomatic. Now, the primary effects that causes signs and symptoms of antemediastinal are because of compression of both respiratory and cardiovascular structures. And I'll be going over each of those systems in a few minutes. In addition to this, the children can also have systemic signs and symptoms such as fever, weight loss, fatigue, etc. And so this could be a reason also why they're presenting to the hospital. As far as effects on the respiratory system, as I mentioned to you before, there could be a dynamic component to this compression as well of the airway, in addition to a fixed obstruction because of the presence of the mass. And this commonly results in various symptomatology, and I've mentioned some of these here: cough, stridor, wheezing, dyspnea and exertion. And one really important symptomatology that we should be focusing on is orthopnea. So the child getting increasingly short of breath when placed in the supine position usually is a bad sign. And I would recommend you pay attention if the child has that particular symptom. And in the presence of 3 or more of these respiratory signs and symptoms usually is indicative or predictive of increased perioperative complications. So asking about each of these signs and symptoms in the history and during the physical examination is really important. In addition to this, if there's pleural involvement, that these children can have chest wall plain, or sometimes there could be a pleural effusion as well. Moving on to the cardiovascular system, depending on where the mass is and what structures is compressing, it can cause symptoms, signs and symptoms of SVZ syndrome that is characterized by facial swelling, neck swelling, and obviously this results from the impaired venous drainage from the SVC. And I'll show you some pictures of SVC obstruction that is detected on CT scan. The mass could also be compressing on the pulmonary artery, and that can result in an increase in the pulmonary vascular resistance, eventually leading to right heart failure. If there's involvement of the pericardium, these children commonly have effusions as well that might need a pericardiocentesis. And often, if this go undetected, if they are very large, they can have tamponade physiology as well. The signs and symptoms of the cardiovascular compression are listed here. So these children commonly have the same shortness of breath, fatigue, orthopnea, etc. And during the physical examination, you should be looking for a raised jugular venous pulse, look for neck swelling, facial swelling. Are there any changes in the blood pressure depending on the position? And of course, looking for arrhythmias and pulsus paradoxus is critical as well. Now, a comprehensive preoperative evaluation or workup of a child with an antemediastinal mass is crucial. So, as I mentioned to you before, doing a thorough history and physical examination is critical, and then asking for signs and symptoms of orthopnea, shortness of breath, any changes with the different positions of the patient should be elicited. In addition to the routine blood test, we do a complete blood cell count, a basic metabolic profile, and then markers of certain oncological markers often are routinely tested as well. As far as imaging goes, most of these children get a chest X-ray to work up these masses. In addition, they could either get a CT scan or an MRI, and I'll go over both of these imaging modalities. Another important part of the preoperative workup is doing an echocardiography and I'll discuss that also in a little bit of detail. Now, the role of pulmonary function tests are kind of controversial. They used to be performed, and but in this day and age, at least at our institution, we routinely do not perform pulmonary function tests because they kind of not really reliable when you do it in these young children, and they kind of gotten out of favor. But a lot of the literature talks about peak expiratory flow rates and a 50% reduction of PEFR being a significant marker, etc. I came across a lot of that in the literature, but it's, again, as I mentioned to you before, the role of PFTs in working up a child with an anti-mediastinal mass remains kind of controversial. We'll start off with a good old-fashioned chest X-ray, which often will show the widening of the mediastinum that's illustrated in this picture. And obviously, this is a much more central anti-mediastinal mass compared to this child that presented to our hospital with a whiteout on the left side. And then you can see like the anti-mediastinal mass extending all the way on the right side. There's an element of tracheal deviation all the way to the right side as well, and a big pleural effusion on the left side. This same child ended up getting a CT scan, as you can see here, which obviously provides more finer detail, and you can see the compression at the level of the carina here of the trachea, and if you scan more distally, there's compression of the bronchi as well. This is more distal picture showing a huge, actually, anti-mediastinal mass. Again, with the pleural effusion on the left side, and you can see there's compression of the bronchi even more distally as well in this particular child. So this would be a really difficult case to take care of. Now, as I mentioned to you before, a CT scan is kind of routinely performed in these children to further delineate the anatomy and to look for signs of tracheobronchial compression. Now, what we specifically look for is calculating the tracheal cross-sectional area, and two kind of red flags, so to speak, are a tracheal cross-sectional area less than 50%, or if it is greater than 50%, but if there's evidence of bronchial compression. So these are two things that put children in the high risk category. And so calculating the tracheal cross-sectional area is routinely performed when we're doing a CT scan. Now, comparing a CT scan with an MRI, the advantage of a CT scan obviously is it's more readily available, and it tends to be a quick 1 or 2 minute scan, as opposed to an MRI, which can take 30 minutes to an hour. Obviously, the downside is the significant amount of radiation that the child is receiving compared to an MRI, which has no radiation. The MRI probably provides more a detailed evaluation, especially of structures in the posterior mediastinal, but because it's a much more longer scan, it takes the child will probably need to get a little bit of sedation before getting an MRI. And so we typically do not perform MRIs routinely for the evaluation of anti-mediastinal masses. All right. Moving on to an echocardiogram, as I mentioned to you before. This is kind of standard in evaluating a child with an anti-mediastinal mass. We're looking specifically at what cardiac structures are being compressed. Is there evidence of right ventricular compression? Is there evidence of any compression of the SVC or the pulmonary arteries? Calculating the ejection fraction and the shortening fraction of both the RV and the LV is important. And finally, also looking for pericardial effusion and is there any evidence of tamponade physiology? And often, if the child is cooperative, we'll try to do the scans both in the supine and the upright position to see if there's any dynamic component to this to compression. As I mentioned to you before, compression of the SVC could be a big deal. This is a significant anti-mediastinal mass. You can see here that there's compression of the SVC, and there's a dilation proximal to the stenotic segment here of the SVC. And this child obviously had symptomatology of SVC syndrome that's characterized by swelling of the face and the neck. Now, I put up the slide here to show that there are several things that can be done to diagnose an antemedicinal mass. And the primary aim of either doing a biopsy is to make a diagnosis, right? And so what I'm trying to highlight here is that it's not always necessary to get a sample directly from the mass in the mediastinum by performing something very invasive like a video-assisted thoracoscopy or a mediastinoscopy. If the aim is to make a diagnosis, the approach should be to see if there's something else that's more superficial and less invasive. So doing a complete physical examination to see if there's any lymph nodes, that a cervical lymph node that can be biopsied, either a direct biopsy or a core needle aspiration or a fine needle aspiration often can be done, because that's the primary aim, is to make a diagnosis so the chemotherapy can be started. So what I'm trying to highlight here is that if you can do something, or if actually the oncology team can do something that's less invasive, that avoids general anesthesia for a much more invasive procedure, such as a mediastinoscopy or a video-assisted thoracoscopic surgery, that should be done. And after the diagnosis is made, is to start the chemotherapy as soon as possible. And so at our institution, one of the things that we focus on is looking for a much more superficial way to make and less invasive way to make a diagnosis. So it could be a bone marrow aspirate biopsy, it could be a pleural tap, it could be a lymph node biopsy. And so we rarely ever have to do much of the much more invasive procedures listed here. As in any anesthetic we take care of, I think risk stratifying these children is really important. And so I've highlighted here low risk, intermediate risk, and high risk patients. So the low risk patients are children who are typically asymptomatic. They have no postural symptoms. On imaging, there's no evidence of any airway compression. There's no cardiovascular compression, yet they have that widening of the mediastinum. And so these are, and they're usually asymptomatic. So no orthopnea, no shortness of breath, et cetera. And it probably doesn't matter how you do general anesthesia for these cases. And so those are the low-risk patients. On the other hand of the spectrum, if the child has orthopnea, stridor, or cyanosis, these are probably three things that I would focus on in the history and the physical examination. In addition to that, on imaging, if they have a tracheal cross-sectional area less than 50%, or if it is greater than 50% but has bronchial compression, those are red flags on the CT scan. If there's evidence of an SVC syndrome or the evidence of tamponade physiology, these are high-risk patients. These children should not get general anesthesia as far as possible. And then there's the intermediate risk patients with children with mild to moderate symptoms with a greater cross-sectional area, and there's no evidence of bronchial compression. So that's kind of in the middle. So again, to highlight this again, low-risk patients are typically asymptomatic. There's no compression of the airway or the cardiovascular structures. On the other hand, things that we look for is the cross-sectional area less than 50% of the trachea, or if it is greater than 50%, but with bronchial compression, and then evidence of SVC syndrome or tamponade physiology. Another thing that I want to talk about very briefly is doing things pre-biopsy to reduce the size of the lesion. And these are, you'll find literature about pre-biopsy irradiation or giving steroids or giving chemotherapy. While the oncologists really don't like to do this, and for several reasons. Obviously, irradiating the lesion will obviously delay the diagnosis. They're not sure what exactly they're treating. The oncologists also do not like giving steroids pre-op, and you should not be a part of the anesthetic in the initial phases for multiple reasons. And let me highlight those here. One is that giving steroids often will make some of these children ineligible for clinical trials. And so that's a huge dissatisfier for patients and their parents, that these children are not able to get involved in clinical trials. Number two, giving steroids often will also delay the diagnosis. And so the oncologists hate doing that. And number three, you can also get tumor lysis syndrome from the administration of steroids. And so, and with hyperuricemia and increased lactic acid levels, etc. And so the oncologist also will discourage us from using steroids. So while taking care of a child with an anti-mediastinal mass, we should not be giving dexamethasone for post-op nausea vomiting prophylaxis because for the reasons that I mentioned before. And finally, giving chemotherapy without actually knowing exactly is probably not a prudent way to manage the child. And so the oncologist obviously will not be on board for that modality. Now, moving on to the anesthetic considerations, we talked about how these masses have compressive effects. Now, in addition to that compressive effects of the masses, a lot of our induction agents will decrease SVR and further decrease cardiac output. And after the administration of most of our induction agents, and there is a loss of airway muscle tone, which will actually further compromise the airway. And so that should be kept in mind as well. In addition, controlled ventilation increases the intrathoracic pressures, will also probably increase the degree of tracheal or bronchial compression. And we talked about how positional changes from sitting to supine can because of the gravitational effects, can further cause tracheobronchial compression. And another thing to keep in mind is you might be able to intubate the trachea and have your tube in the trachea, but if the compression is in the distal trachea or tracheal bronchus, as long as you can bypass that obstruction, you're probably not ventilating the lungs effectively. And so that also has to be kept in mind. So that's why avoiding general anesthesia is critical in just as much as possible. So as far as the anesthetic plan goes, something I want to highlight here is having a multidisciplinary approach. So talking to the oncologist, the surgeon, the ENT surgeon, etc., beforehand to have a good plan in place is really important. We must avoid general anesthesia as much as possible, especially in these high-risk children. If you have to do an anesthetic, maintaining spontaneous ventilation is critical. The negative intrathoracic pressures with spontaneous ventilation will make sure that you're not worsening the compression of the mass from the mass. We talked about avoiding neuromuscular blockers because, again, as I mentioned to you before, that is going to decrease muscle tone of the airway and is going to further worsen the compression. Having a good IV access pre-op will probably be prudent. And I can't emphasize the next step of having a skilled help. This is not a case you want to be starting in the middle of the night in one corner of the hospital that nobody can get to. This is where you want to call a friend, you want to have skilled help available, so you're not managing these children on your own. Having a backup plan is really important. And so identifying pre-op, what is the rescue position that actually makes the child feel better? So the rescue position could be having the child sit up or going in the left lateral or the right lateral position. So having a plan for can we reposition the child after anesthesia to make symptoms better? So knowing that before you start the anesthetic is critical. But what I want to emphasize here is avoid general anesthesia as much as possible. And more important than what drugs you give for this sedation, I think the important piece is how you give it. And the key, I think, is to give small doses titrated to effect. Popular choices are giving dexmedetomidine, which has become such a popular drug. I heard yesterday somebody telling me that dexmedetomidine is like bacon. As a meal in itself, it's not good, but you can add it to anything and it makes everything taste better. So dexmedetomidine in small doses is often used, titrated to effect. Ketamine is also another drug that's used a lot while managing children with anti-mediastinal masses. But what you don't want to do is give a big slug of propofol because that can quickly land you into a lot of trouble. I got these figures from one of the references that I'll be highlighting later in my talk. But if the child is low risk, yes, it's probably not a big deal to do general anesthesia. It's important to keep the child breathing spontaneously. Having a backup plan, as I mentioned before, so having an ENT surgeon in the room with a rigid bronchoscope Consider need for preoperative steroids. I kind of don't agree with that. And I told you why I think it's important to avoid steroids. And if you're really concerned about cardiopulmonary bypass, that should be probably a high-risk patient. And with patients with high risk, avoiding general anesthesia is critical. Is there a way for the oncologists or the surgeons to make a diagnosis using more peripheral and easily accessible lymph nodes, et cetera? That should probably be the way it's done. And these, with general issues of local anesthesia plus or minus sedation and have a backup plan, I think is important. And obviously, if there's deterioration, if there's respiratory compromise, obviously the first thing is calling for help, increasing their FiO2, avoiding using gentle positive pressure with CPAP to see if you can open up the airways. And I also mentioned before that whole repositioning. So having a rescue position, knowing what that is pre-op, I think is really important as well. And then this also talks about one lung ventilation. So if there's significant tracheobronchial compression, or primarily one main stem bronchus, considering advancing the tube distally so you can bypass the obstruction. We also talked about having an ENT surgeon for rigid bronchoscopy. And if there's cardiovascular compromise, which is not uncommon, is to give obviously start with a fluid bolus, reducing the depth of the anesthetic, reposition the baby, and it all fails, obviously, do a sternotomy, which it's easier said than done. And of course, there's always the option of ECMO, which is, again, it requires a lot of planning. It's not something that you want to call in the last minute and hope that you can have a good outcome. So I'm going to use this slide as kind of my summary slide. This is our algorithm that we use at our institution for diagnosing, working up, and managing a child with an anteromeatal cell mass. So it starts with, asking for doing a detailed history, looking for some signs and symptoms of tracheobronchial compression and cardiovascular compromise. So looking for respiratory signs, it lists out cyanosis, orthopnea, wheezing, cough, stridor, etc. Looking for SVC syndrome, so venous congestion, plethora of the face, neck swelling, facial swelling, etc. These children all usually end up going to the pediatric ICU. The labs that are listed there, the CBC, LDH, uric acid, HCG, and AFP levels, a standard routine chest X-ray, and often a chest CT also is performed. PFTs, it says plus or minus. We don't routinely do that anymore. And then there's the echocardiography, where you're looking for the shortening fraction, looking for tamponade physiology. And as if there's evidence of any of those pericardial effusion, they still and often will need a pericardiocentesis. And if in the CT scan, we look for the degree of tracheal compression. And as I mentioned to you before, calculate the percentage of tracheal cross-sectional area. If it is less than 50% is not good, or if it is greater than 50%, but with evidence of bronchial compression, that also should make you worry. We look for the degree of vascular compression on the CT, look for pleural effusions. And if the child is in the low risk category, again, the focus should be on trying to make a diagnosis using more superficial structures. But if it's okay to do general anesthesia. On the other hand, if the child has any of the features that I talked about, puts the child at high risk category, you should not be doing general anesthesia as much as possible, and using more superficial structures to make a diagnosis. I promise I'll give you two good highlights, highlight two good papers. This is actually from our institution. Guy Tan is one of my colleagues. She was supposed to be joining me this morning, but couldn't make it because she has another commitment. But this is a good review article on anteromeatal cell mass, and that you can scan that QR code. And this is something that came out very recently in 2019 from, was published in BJA Education. Again, that QR code should take you directly to that article, and it highlights most of the things that I mentioned today. Again, thank you so much for this opportunity. That's my email address and my Twitter handle.
Absolutely brilliant. Thanks, Dave, for that enlightening talk. It was clear, succinct, and you highlighted all the challenges why we shouldn't touch these patients unless absolutely necessary. Great. So I have one question. Obviously, one of the risk stratification is evaluating their CT, and very often small children need anesthetic help for a CT, and getting anesthetizing the children in the CT scanner for this procedure is the worst place you want to be. Do you have any thoughts around it? How you navigate this in a symptomatic child needing a CT to get to the next step?
Yeah, that's an excellent point. Getting a CT scan is definitely an integral part of the workup. We avoid general anesthesia, obviously, for the CT scan.
Mm-hmm.
And the good thing about the CT scan is quick. It's like a 1 or 2 minute scan. It's not like an MRI. And we have virtual distraction goggles. We have iPads that we use to to distract these children for the CT. But the problem is often these children are not able to lay completely flat because of the whole orthopnea and the compression. And so the radiologists are willing to work with doing the CT scan almost in a 45-degree head up position. And so we've gotten away with it. So we are physically in the room sometimes to help with the CT scan, but we do not anesthetize these children. We have an agreement with the radiologists, like we are not touching these children. And so we are going to help, but we'll use other virtual distraction or other strategies to help with getting a CT scan and try to get it in the 45-degree head up position, or having the parents in the room, etc. So again, good point, but we do not anesthetize the kids for the CT.
Okay, excellent. Yeah.
I mean, it might sound stupid, but all these CT scan, modified scans where they can actually move, because you're saying that they are actually, because adult CT scans or MRIs, obviously they are static. So how do you get the dynamic kind of scans? So it must be special ones for kids. Am I right?
No, it's the same regular CT scan. They just positioned sitting up. So we have pillows on their back.
That's true.
And they're taking the pictures. So if I'm not mistaken, it's not any kind of special, and then they just have a different angle at which I think they scan these,
Yeah, that's why I was thinking, yeah. I don't know whether it's physically, the whole thing moves, or is it just they are able to actually do it, kind of thing. I know that there are now open MRIs where you can actually sit patients and actually do that. So, but I was just wondering how they actually get good images with sitting up or 45-degree incline. Yeah, I did also the same question was Jordi had. It says, he was saying that no GA, but some of these patients probably require some support, but obviously Dave has answered that.
Even I had the same question regarding that, like how do you get scan without anesthesia? So we were involved, the cardiac team was involved if it had come for surgery, but then one of our colleagues had already briefed us on this case. So she went in and again, this was around probably a 3 or 4 year old kid who had a CT, who was supposed to have a CT scan. So when the kid was made to lie down, that time without anesthesia, without anything, it just desaturated. And then you say that you're not involved, but you're there, but you're not involved, and you don't give general anesthesia. What if you are not able to get a scan? Like, is there any alternative, or it's like, how is that you are there but not involved? Like, how is that?
So again, as I told you, it takes a village to take care of these children, and most of the times there's child life specialists. There's having the parents in the room obviously will help, allay some of the anxiety. It's a lot of vocal anesthesia and not general anesthesia, and if push comes to shove, if the child needs something, I would consider using a small dose of dexmedetomidine or midazolam or ketamine. But again, most of the times we try not to get involved. And our oncology team and our, the child life specialists, et cetera, and the radiologists, they're willing to do whatever it takes so that, we can get these scans without actually sedating these children as much as possible. So either having iPads, having parents in the room, having a virtual distraction goggles, something that can avoid general anesthesia as much as possible. Is what is the approach I would recommend.
Right. Thank you.
Very
Yeah,
interesting.
same here. So the radiologists and are very helpful. Even the oncologist is very helpful in our hospital. And in this child, the father was there, and even with the father being there, just being supine, it led to all this desaturation. Yeah, thank you so much. Yeah.
I think Parin has got a
My question is, can we feed this child like those who are on bottle feed or on breast milk? Can we feed them and let them sleep in their normal position so that at the time of CD they may sleep in their normal position at what they were comfortable at their homes? And since it is a small procedure,
in the really small babies having MRIs, not for mediastinal masses, but again, like if a really small baby needs an MRI, we have this program known as feed and swat and swallow, where they would actually like bottle feed the child or breastfeed the child, whatever, and then they swaddle the baby, and like, you know, almost like the baby falls asleep and they're able to do a 30-minute MRI. But again, recognizing that, you know, feeding the child will preclude us from doing any kind of sedation. So it's a fine balance. And as long as you're not planning on giving any sedative or general anesthetic, I think it's okay to feed the child. And if the primary aim is to get the CT scan, as I mentioned to you before, a CT literally takes a couple of minutes. And so whatever you can do to avoid general anesthesia, I think is important. And as I highlighted before, their child does not have to be completely supine. It could be a little bit of an angle, a little bit of a bump under the head and the shoulders, so that the child is not completely flat. Because as Vikram mentioned, that's going to cause the child to desaturate.
thank you, sir.
One of the questions I have, Dave, is around many of these pathways will have like cardiopulmonary bypass as one of the options. Do you ever enlist this surgeon standby? Does it work? I mean, it's not a feasible option once the kid is already desaturated.
I think having the ECMO team on standby is something that's done relatively infrequently, but I've heard about it. Again, personally, I've not had taken care of a child with that degree of anti-mediastinal mass that requires general anesthetic. But having an ECMO team on standby will be helpful. Again, this is one of those things where you want to plan ahead, let them know. It should not be as the child is desaturating, you call ECMO, because that's not going to result in good outcomes. So, we have an anesthesia lead at our place who is the primarily involved. That's actually Dr. Gime Tan, who actually coordinates all of this care. So anytime a child with an anti-mediastinal mass shows up at our hospital, she's notified, or if she's not around, somebody else, the anesthesia charge person is notified. And so having this plan, like having an ENT surgeon in the room with a rigid bronch, having ECMO on standby, all those things could be planned ahead. And she sends out an email to the rest of us saying, hey, there's an anti-mediastinal mass in the hospital. If they need a biopsy in the next couple of days, we're going to be involved, and this is our plan. And so it's a well-oiled machine now. And so they know not to request us for general anesthesia, and they know not to request it at Friday at 4 p.m. Because you don't want to be doing these cases alone in the middle of the night.
Excellent. Thanks, Dave. Thanks again.
My pleasure.
Anybody else
Thank you.
have any questions? All right, we will move on to the final talk of the day, pediatric resuscitation life support, and welcome Dr. Kalyani to start our talk, please.
Is it visible, sir?
Yes, Dr. Kalyani.
Yeah. Greetings, everyone, and I would like to thank Sir and Jadi sir for this opportunity to present here. So the last topic for today's symposium, pediatric advanced life support. It's quite a vast topic. I'll try to keep it relevant and short. So coming to the outline of my presentation, I'll be discussing the pediatric chain of survival, the basic life support in short, the advanced life support, the perioperative life support because it is relevant to us, and the updates of 2020 guidelines and why the changes have been made in these guidelines. So as we all know that the cardiac arrest in infants and children, it differs from adults because it is a result of progressive respiratory failure or shock, and hence it needs a different approach as compared to adults. Also, though the survival is improved over the last few years, there is a plateau seen in the last decade, and hence prevention of cardiac arrest is an important link in the chain of survival. And in addition to that, recovery is stressed as an additional link in the 2020 guidelines for both out-of-hospital and in-hospital cardiac arrest for pediatric population. So this is the chain of survival. The sequence, however, is compression, airway, and breathing, similar to adults, for two main reasons. First and foremost, it allows for a consistent approach to arrest treatment in adults and children. And additionally, it results only in minimal delays in commencing rescue breath to the child. One of these studies had shown that the delay is only about 5.7 seconds if compression, airway, and breathing sequence is maintained. High quality CPR is the mainstay of this resuscitation, which includes adequate chest compression depth, optimal rate, minimizing the interruptions in chest compression, allowing full chest recoil, and avoiding excessive ventilation. Coming to chest compression, the rate is 100 to 120 per minute for infants and children. The depth is at least 1/3 of the AP diameter of the chest, which comes to around 4 centimeters in infants and 5 centimeters in children. After each compression, it is important to allow for complete chest recoil, and rhythm check is to be performed, but it should last for not more than 10 seconds and should be done every 2 minutes. Most important in children is one should avoid leaning over the child because their chest is compliant, and hence it will prevent the filling of the cardiac, the return will be reduced, and it will affect the coronary perfusion. And lastly, it should be performed on a firm surface because only then we can achieve adequate depth for the chest compression. The techniques described are a 2-finger technique, which is used for infants with single rescuer, and a 2-thumb encircling hand technique, which again can be used for infants with a single rescuer or with 2 rescuers. The advantage of 2-thumb encircling hand technique is it improves the quality with respect to depth and compression force and is associated with less rescuer fatigue. However, the chest compression fractions are less with this technique, and incomplete chest recoil can occur, especially when performed by a single rescuer. In addition, 1- and 2-hand technique is used in children depending upon the age and the size of the child. Coming to ventilation, the airway is opened by head tilt and chin lift maneuver unless a cervical spine injury is suspected, in which case jaw thrust should be performed. The ventilation is to be done with 100% oxygen during resuscitation. With a single rescuer, the compression ventilation ratio is 30:2, and with 2 rescuers, it is 15:2. As per the 2020 guidelines, the respiratory rate is recommended 20 to 30 breaths per minute for both children who are receiving just rescue breathing and have a pulse, and also for those who are receiving CPR with an advanced airway in place. Now, this is the algorithm for single rescuer, and we've discussed it, and this is for 2 rescuers. The difference is in the compression as to ventilation ratio. Now, coming to the advanced airway, bag and mask ventilation is preferred over endotracheal intubation, especially in out-of-hospital cardiac arrest, and when the transit time is less. Intubation, the most important thing to consider is adequate resuscitation should be provided before attempting intubation in children. Also, the 2020 guidelines recommend using cuffed tubes over uncuffed tubes because the ventilation is better with the cuffed tube. Also, the risk of aspiration is minimized. The capnography is more reliable with cuffed tubes. And most importantly, the reintubation rates are less due to leaks, and hence the pauses in compression are avoided. And if attention is paid to the appropriate size of the endotracheal tube, the position, and if we keep the inflation pressures below 20 to 25 centimeters of water, then the chances of subglottic stenosis are almost nil. So now coming to the cricoid pressure, the 2020 guidelines do not recommend routine use of cricoid pressure during endotracheal intubation. They further reaffirm that the cricoid pressure should be discontinued if it interferes with adequate ventilation with bag and mask, or if it delays the intubation. The reason for this recommendation being that cricoid pressure not only reduces the first attempt intubation success rate, but more importantly, it does not reduce the rate of regurgitation for which it was recommended in the first place. Atropine again is not recommended routinely, but it has to be used as a pre-medication during emergency intubations when the risk of bradycardia is definitely high. For example, when we are planning to give succinylcholine choline for intubation, and the dose is 0.02 milligram per kg. Now, monitoring the exhaled carbon dioxide in patients with perfusing rhythms, qualitative as well as quantitative EtCO2 detectors perform equally well. They not only confirm the placement of the endotracheal tube, but they are most important during transport of the baby either within the hospital or inter-hospital transport. The reason for this recommendation being the findings from the fourth NAP, which showed that failure to use or inability to properly interpret capnography have contributed to majority of adverse events, including ICU deaths. And if used properly, they are effective in preventing adverse events, and they recognize early tube dislodgement. Now, coming to pediatric bradycardia algorithm, if the patient is having bradycardia and is not having a cardiopulmonary compromise, we just need to support the airway breathing, circulation, oxygenation of the child, observe the child, and 12-lead ECG monitoring, identify and treat underlying causes. However, if the child is having a cardiopulmonary compromise, either in the form of hypotension, signs of shock, or acutely altered mental status, then maintaining the patient's airway, assist breathing with positive pressure ventilation and oxygenation as necessary, monitor the cardiac rhythm, blood pressure, and oximetry. Most important, if in spite of all these measures, if the heart rate is still below 6 per minute, then cardiopulmonary resuscitation has to be started. Studies have shown that children who receive cardiopulmonary resuscitation with bradycardia do significantly well if we rather than waiting for the child to develop a pulseless arrest. So if the bradycardia persists, we continue with the cardiopulmonary resuscitation, and epinephrine is given as soon as intravenous or intraosseous access is secured. If the child does not respond to this treatment, and more so if the cause of bradycardia is due to an increase in vagal tone or due to a primary AV block, then atropine is recommended. Transthoracic or transvenous pacing has to be considered in patients who are having acquired or congenital heart disease, which could lead to complete heart block or which could lead to a sinus node dysfunction. Most important in the bradycardia algorithm is to identify and treat the underlying causes. It could be either hypothermia, hypoxia, also hypovolemia, hypoglycemia, acidosis, and medications are most common causes of bradycardia in children. Epinephrine, when given, the dose is 0.01 milligram per kg for intravenous dose and repeated every 3 to 5 minutes. And if intravenous or IO access is not available and endotracheal tube is in place, then the dose is 0.1 milligram per kg. And the dose for atropine is 0.02 milligram per kg. Now, coming to the tachycardia algorithm, the initial assessment and support is the same. The rhythm has to be evaluated by a 12-lead ECG. So the markers for a possible sinus tachycardia include presence of a normal P wave with a varying RR interval, and a sinus tachycardia has usually a rate of less than 220 in infants and less than 180 in children. The underlying cause should be identified and treated. If on ECG it is not a sinus tachycardia and the child is not having any cardiopulmonary compromise, then the management differs on whether the QRS duration is wide or narrow. If it is a narrow complex tachycardia, it is probably a supraventricular tachycardia. In these cases, vagal maneuvers should be considered, which include carotid sinus massage, and most important in children, placing the baby upside down usually reverts the supraventricular tachycardia. However, if it does not respond to vagal maneuvers, then and if the intravenous or intraosseous access is present, adenosine has to be given. I would like to emphasize here that vagal maneuvers are to be tried only when the child is hemodynamically stable. Now, coming to tachycardia with cardiopulmonary compromise. If it is a narrow complex tachycardia, as I already said, vagal maneuvers are not to be tried and directly adenosine is to be given. However, if it is not effective or if intravascular access is not available, then synchronized cardioversion has to be performed. For a possible ventricular tachycardia, that is with a wide QRS duration, synchronized cardioversion has to be performed, and expert consultation is recommended before giving additional antiarrhythmic drugs. Synchronized cardioversion, one must begin with 0.5 to 1 joules per kg, and if not effective, it should be increased to 2 joules per kg. The child needs to be should be sedated if required, but the cardioversion should not be delayed. The dose for adenosine, the first dose is 0.1 milligram per kg rapid bolus, and the second dose, if the first one is ineffective, it will be 0.2 milligram per kg as a rapid bolus. Now, if with all these rhythms there is a pulseless, the child becomes pulseless, then the CPR has to be started and the rhythm should be checked. If it is a shockable rhythm, that is a ventricular fibrillation or pulseless ventricular tachycardia, the first shock is to be given at 2 joules per kg, and CPR should be resumed immediately after shocking without a rhythm check, and intravenous and intraosseous or intraosseous access has to be secured. After CPR for 2 minutes, the rhythm should be checked again, and the second shock should be 4 joules, is a 4 joules per kg. And after that shock, again, the CPR has to be started immediately after shocking the child, and epinephrine is given. The first dose is given, and it is repeated every 3 to 5 minutes, and consideration should be given for placing an advanced airway. And the rhythm should be checked again. If it is a shockable rhythm, the shock can be increased to more than 4 joules, but the maximum shock should not be more than 10 joules per kg, or it should not exceed the adult dose. And the next treatment which is recommended is amiodarone or lidocaine. By this time, if any reversible cause is apparent, it should be treated. If in the first place the rhythm is not shockable, that is, it is persystole or pulseless electrical activity, then epinephrine has to be given as soon as possible and CPR is started. And anytime if the rhythm becomes shockable, then the shock algorithm has to be followed. Now, coming to management of shockable rhythm, they definitely have a better outcome as compared to a previous non-shockable rhythm. It can be either a primarily shockable rhythm, or during resuscitation, a non-shockable rhythm can be converted into a shockable rhythm. Shorter the duration of this rhythm, the more likely that it will revert to a perfusing rhythm. Defibrillation is the only definitive treatment for this rhythm, and it is important to coordinate the shock with the resuscitation. The CPR has to be performed until the device is ready to deliver the shock. A single shock technique is recommended over stacking of multiple shocks, and it should be immediately followed by chest compression because it is associated with significant survival benefits, and it is important to minimize interruptions in chest compression. Now, coming to the defibrillation, paddles and self-adhering pads both are effective in terminating the rhythm. The largest paddles or electrodes possible should be used, that will fit the chest, but at the same time maintain a good separation within themselves, because the paddle size is the most important determinant of decreasing the transthoracic impedance, and hence it will determine the delivery of shock to the child. The placement can be either anterolateral or anteroposterior. Manual defibrillators are preferred when healthcare personnel are delivering shock, because in that case the energy levels can be adjusted manually. Biphasic defibrillators are used now because less energy is required to achieve termination, and they are associated with fewer side effects. The doses we have already discussed. AEDs, when used, it is preferable to use a pediatric attenuator, especially for infants, and when the children are less than 8 years or less than 25 kg, because the AED without the attenuator delivers a shock of around 120 to 360 joules, which is pretty high, above the maximum dose. However, if the attenuator is not available, the shock should not be delayed because that is the only life-saving intervention. The drugs we have discussed. Most important, I would like to mention here that the drugs have to be given according to the dose, and in any case, the adult recommended dose should not be exceeded. And all these drugs, they should be followed by a flush of around 2.25 ml per kg, which comes to around 5 ml in infants and 10 ml in children. The intravenous intraosseous dose of epinephrine is 0.01 milligram per kg, repeated every 3 to 5 minutes, and endotracheal dose is 10 times 0.1 milligram per kg. The 2020 guidelines have emphasized on administering the first dose of epinephrine within 5 minutes of starting the chest compression, because every minute delay in the first dose significantly decreases the survival chances of the baby. Amiodarone, the dose is 5 milligram per kg bolus, and up to 3 doses can be given for refractory ventricular fibrillation or pulseless ventricular tachycardia. It increases the success rate to defibrillation. Lidocaine, 1 milligram per kg loading dose. Sodium bicarbonate is not recommended routinely, and it is shown to worsen the outcome. It should be used only when there is documented evidence of hyperkalemia or toxicity with sodium channel blockers like tricyclic antidepressants. Similarly, calcium should be used only when there is documented evidence of hypocalcemia, hyperkalemia, or toxicity with calcium channel blockers. It should not be used routinely. Now, it is important to assess the quality of CPR. End-tidal carbon dioxide reflects not only the cardiac output produced by chest compression, but also gives us an idea about the ventilation efficacy and is most important. If invasive arterial blood pressure monitoring is already in place, we should target for a diastolic blood pressure of 25 millimeters of mercury in infants and 30 in children for adequate coronary and cerebral perfusion. Various CPR feedback devices are available which improve the compression rate, depth, and recoil. Bedside echocardiography, if trained individuals are available, is definitely useful in identifying reversible causes of cardiac arrest like pericardial tamponade or low cardiac filling. However, the risk, the benefit must be weighed against delay in the chest compression. And if it is significantly high, then only bedside echocardiography should be used. Now, coming to pediatric perioperative life support. So, if there is a cardiac standstill in the operating room, no doubt it has the best chances of resuscitation and recovery with anesthesia personnel present in the OR. And hence, there are minimal no-flow and low-flow intervals. So, the no-flow interval is from the moment the baby sustains the cardiac arrest to the beginning of resuscitation, and low-flow is from the beginning of resuscitation to return of spontaneous circulation. Both these intervals are expected to be minimal in an operating room setting. The risk of perioperative arrest is inversely related to the age of the child. It is highest if the child is less than 1 month, and by teenage, it is equivalent to that of adults, and it is related directly to the ASA status of the child. Now, what are the causes of perioperative arrest? The most common contributor is hypovolemia, which could be either pre-existing or it could be due to inadequate replacement of ongoing losses during the surgery. Pre-existing hypovolemia is rare now due to liberal fasting guidelines. Inadequate replacement is more common in surgeries which are associated with major blood loss. Having a central venous access definitely is helpful to prevent this because it will help us to assess the volume status as well as help us replace the losses. Hyperkalemia is the second important cause. It could be due to rapid transfusion of large volume RBCs, especially if they are stored for more than 2 weeks, and it is more common with irradiated red blood cell transfusion. Succinylcholine, when used in patients with burns, direct muscle trauma, neuropathies, or myopathies causes significant hyperkalemia. Laryngospasm due to any cause can lead to arrest, right from induction to inadequate depth or during extubation. Inhaled induction, this is a less frequent cause now with the use of sevoflurane. With halothane, it was more common because halothane is a direct cardiac depressant, and also because the halothane vaporizer, it was possible to deliver higher Mach multiples of halothane, which is not the case with sevoflurane. Again, hypoxia from various reasons can lead to arrest. Bradycardic arrest is ominous because children have a cardiac output which is dependent on the heart rate. It could be due to drugs like succinylcholine, neostigmine, or due to any procedural traction, any pressure on the neck, eyes, or heart, or laparoscopic insufflation of the abdomen. The less frequent causes include venous air embolism. Local anesthetic overdose in children is important because the anesthesia is usually given after general anesthesia, and hence the initial signs of anesthetic overdose are masked because of general anesthesia. A relative anesthetic overdose, a child who is already compromised, if he is induced on weight basis, he will definitely have a relative overdose of anesthesia. And hence it is important to anticipate such children and titrate the induction doses and maintenance doses in these children. And other causes include malignant hypothermia and anaphylaxis. The management, first and foremost, CPR is the initial and most crucial response to perioperative cardiac arrest. Simultaneously, attempts must be made to eliminate factors that could contribute to deterioration. We'll be considering that in a flowchart shortly. Simultaneous efforts to determine the cause of the arrest and administering specific therapy. However, the cause may not be immediately apparent, and hence it is important to have a systematic approach to resuscitation to avoid missing suitable conditions. Most important, it is important that we recruit incremental help rather than crowding the OR and increasing the chaos and delaying the resuscitation. So the help should be recruited as required, and how much staff is required, that much should be recruited to the OR where there is the arrest scenario. And assignment of role for resuscitation, including leader, the person who will be managing the airway, the person who will be in charge of the medications, defibrillation, monitoring, and records, they should be assigned so that the delays are avoided and the survival benefits are increased. Now, this is the algorithm for intraoperative arrest. As we just discussed, CPR has to be initiated, assign roles, attach defibrillator, call for incremental help, stop the surgical stimulus. If the child is not already intubated, intubate the child and monitor the EPCO2, the goal being more than 10. Also, the FiO2 has to be increased to 1. Inhalational agents are stopped. Potentially deleterious infusions and medications should be stopped, which include opioids, patient-controlled anesthesia, non-depolarizing muscle relaxants, local anesthetics, any hyperalimentation, blood transfusion if it is ongoing, it should be stopped. Vasodilators, protamine, dextran, and latex, these have to be stopped. The rhythm has to be assessed, and the further management depends upon whether the rhythm is shockable or not shockable. Here, I would like to mention that if local anesthetic toxicity is, then it is important that we avoid lidocaine and procainamide because they are themselves sodium channel blockers, and hence they may increase the toxicity of local anesthetic. So only amiodarone has to be given in local anesthetic toxicity. Now, in patients where the surgery is in prone position, the child may develop arrest, and in such cases, prone resuscitation has been shown to improve the outcome. So it can be given, or it could be given bilaterally over the scapula, and the prone CPR has to be continued till the child can be made supine. The assessment of the effectiveness of compressions is suggested by production of adequate levels of EPCO2. If the levels are not adequate, then sternal counterpressure is given either with a sandbag or with a closed fist, and the efficacy has to be monitored. Defibrillation is also described in prone position away from the incision and over as much of the heart as possible. This should be continued till the child can be made supine. Now, I would just in short summarize the updates in 2020. This is a good article which is titled as More Breath, Less Fluid and a Focus on Recovery. So they have divided it in pre-arrest care. They emphasize the use of, in 2020 guidelines, the use of extracorporeal life support has with myocarditis, because and it should be done preemptively, because as we just discussed that the institution of extracorporeal support requires time, and hence such babies should be identified, and if it is instituted in time, it will not only support the organs but also prevent arrest in these babies. Coming to septic shock, the guidelines of fluid resuscitation, either crystalloids or colloids can be used for one fluid over the other. Also, the 2020 guidelines uniformly recommend a cautious approach to fluid resuscitation of 10 to 20 ml per kg, and the baby has to be monitored both for volume responsiveness, that is fluid responsiveness, as well as signs of volume overload. Regarding inotropes in fluid refractory septic shock, norepinephrine or epinephrine can both be given, and there is no distinction as warm shock guidelines in 2020. If the child in sepsis has the arrest, it definitely has a worse outcome than any other cause. However, the routine protocol has to be followed even if it is an arrest in sepsis. In intra-arrest care, we have covered all the points, including advanced airway during CPR. Both the advanced ventilation as well as advanced airways have shown to have equal benefits. Respiratory rates have been increased to 20 to 30 breaths per minute, preferred over unperfused. Cricoid pressure is not routinely recommended and has to be discontinued if it affects the ventilation and intubation. Early epinephrine within 5 minutes of start of chest compression, using invasive blood pressure during CPR. And more importantly, there is an addition of opioid-related cardiac arrest. However, a routine protocol has to be followed, and one must not delay cardiopulmonary resuscitation while awaiting naloxone because that is associated with the. Coming to post-cardiac arrest care, it is important that the child receives adequate care because it develops a post-cardiac arrest syndrome which is associated with secondary organ damage. Targeted temperature monitoring is important, either with normothermia or hypothermia followed by normothermia. It is important to monitor the core temperature continuously. Hemodynamic monitoring with invasive blood pressure is recommended because the blood pressure is very labile and non-invasive viable. Ventilation to maintain a normoxemia and normocardia. Neuromonitoring, EEG monitoring is most important because these children are not only at high risk of developing clinical seizures, but non-convulsive status epilepticus is very common and it has an equally worse outcome. Regarding prognosis in these children, certain EEG patterns definitely are in favor of good prognosis, which include a normal reactivity. However, ECG prognosticate and many factors have to be considered in prognosticating the survival and the outcome of these children. So this is the pediatric post-cardiac arrest care checklist, which has to be followed meticulously. And lastly, recovery is the most important link in these patients because these children, majority of them, not only have physical morbidity, but they have almost 85% of them have emotional challenges and quarter of the survivors. And hence, an integrated approach is required so that we can have a good survival in this vulnerable patient group. Thank you so much. These are my links.
Thanks, Dr. Kalani. That was an exhaustive presentation. I know it's a very difficult topic to cover. You did a fantastic job. Thank you very much. I know it's, like there is this standard pediatric life support algorithm, and then you have to mix it with our practice as anesthesiologists and tailor it to our talk.
Can I ask Kalyani to stop sharing our screen so that you can see the faculty?
Yeah.
Thank you.
So I do have one question. There is an increasing use of compression-only CPR in the obviously it's out of hospital non-anesthesia providers or laymen CPR. When it comes to pediatric patients, they still probably benefit because many of the cardiac arrest causes may be respiratory in origin. They still need ventilation as a primary mode of treatment. Has there anything mentioned in the current literature around that in terms of
no, sir, there's nothing mentioned about compression only CPR. The only mention is that the sequence has to be the same, like compression, airway, breathing, but definitely breaths, ventilation is important.
Yeah.
Like, as far as it is not delayed significantly, it is fine, but it is important.
Yeah, just that because the adult causes are more cardiac in nature, whereas the pediatric causes are more respiratory in nature. However, the compression only may not be very effective, especially in the cause. Dave has put up the cognitive aid link. That's a great suggestion, Dave. There should not be any shame in pulling out these aids to help us in managing the scenario better. Because I mean, in the moment of crisis, our cognition load is too much in managing these patients. So delegation is very important. As you said, incremental help is important. Use of cognitive aid is very important. I'll ask if other panel members have.
Can I just mention something on that?
Yes, Dave.
So the use of cognitive aids, is becoming an integral part of all resuscitations. I provided a link in the chat on the PD Crisis app that was developed by the Society for Pediatric Anesthesia. Obviously, this is the one that we use here. But it's, as Jari mentioned, there should not be any shame in using it because it's impossible to remember all of this stuff. So all of us have these downloaded on our phones. And during any resuscitation attempt, actually one person is designated to open the app to make sure that they're doing all the steps. When we even debrief after the event, one of the questions we always ask is like, was anybody looking at the app to make sure that we did all the things we were supposed to? So that has become an integral part of any resuscitation attempt to use cognitive aids because it's impossible to remember all of these things, especially in a stressful situation. So again, I'm biased towards the PD Crisis app because I'm involved with the SPA and so But it's available for free. It's a fantastic app. I would highly recommend it.
I wasn't follow. There are a couple of questions for Dave's presentation. The one there was no there's no questions for Dr. Kalyani yet. So Dave, there was a couple of questions for your talk. One is from Dr. Naresh Paliwal. He was asking what procedural sedation will he choose? You did mention a few things. Do you want to take that?
Sure. So for procedural sedation, my preferred drugs would be to use dexmedetomidine and ketamine, titrated to effect. So those would be the first two drugs that I would use. And if I need more than either of these two drugs or a combination of both of these drugs, I would use small doses of fentanyl and midazolam if necessary. But again, more importantly than choosing the drug, I think how you use the drug is important. So titrating these drugs, but my first two choices will be ketamine and dexmedetomidine because they allow the patients to be breathing spontaneously and provide sedation as well. And I saw this. Sorry.
Yeah. I think the reason why Dr. Paliwal has actually asked this question is he actually uses combination of ketamine and dexmedetomidine. I think he's very interested in knowing that is it being used abroad as well by the pediatric guys, especially like for these cases. Wouldn't it be a great combination to use?
Yeah, absolutely.
Yeah, it will be absolutely brilliant.
Yeah. Both ketamine and ketodex, yes. We use them together.
Yeah. And what combination, what is your, do you actually have a ratio or a specific combination you use, or just you do use like different syringes, or you mix in a syringe?
We are not allowed to mix drugs in syringes.
Yeah, that's true.
And so we use them separately. So usually the dexmedetomidine would start with like 1/2 mic, 1 mic per kilo boluses, given slowly over 5 to 10 minutes. And the ketamine is again, depending on the effects, but usually start at 0.5 to 1 milligram per kilo and then titrate slowly to effect.
Okay.
So, but we're not allowed to mix syringes, so we just use them separately.
Yeah, the other thing would be like with ketamine, we normally do actually give benzodiazepines in adults, but in children, obviously, I think the doses you use, you don't actually have to worry about it. And does dexmedetomidine take care of the post-op?
Delirium, yep.
Yep. Yes.
Again, dexmedetomidine is being used like water. Everybody gets Precedex now, so it's all good.
It's still costly, isn't it? In UK and US, it is still costly. And India, it's pretty cheap comparatively. Yeah. So it's been used, I think, in India than. Yeah, they have great experience.
I mean, we tend to share a lot. I mean, it's sort of we send a WhatsApp group, and the first question every day is that who has opened a Dex vial? That's the commonest question we have, and then we share. Because in pediatric practice, most of our patients don't need more than like 4 mics, 8 mics, 12 mics. So we have like 200 mics vials, so we dilute it. So 4 mics per ml, 50 cc's lying around. So probably we have like 23 ORs running. So it's easy to share, and the cost of the vial is around $60, I was told. So it's not a big expense compared to, because you can spread it out a lot.
Yes. Okay, that's interesting because we're not actually allowed to share the drugs. That's the other thing, especially
we are not. Yeah, we are not allowed to share opioids. It doesn't come to dexmedetomidine.
So our pharmacy actually will make out pre-filled syringes. So they take a dexmedetomidine vial and they make out like multiple. So we get actually dexmedetomidine in 4 mics per cc, and we'll get 12 mic syringes, and it's kept in the pharmacy. And so you grab how many ever you want. So they're able to create these little aliquots. So we are not doing the actual dividing. It's done by
Yes,
the pharmacy in
okay.
a clean fashion. And that has been a lifesaver for us.
Yeah, I think that's people have to find their own innovative ways of doing that, isn't it? And that's where pharmacy actually comes in. If they are actually helpful, that are helpful.
Yeah.
They did it for us for diamorphine, spinal diamorphine, because we only use 500 mics and each is 10 milligram or 5 milligrams. So they make now sterile 500 microgram syringes for intrathecal use. So I think similarly, one of our co-hospitals, it actually used they have ketamine like that, already prepared for use. Saying that ketamine is not a very costly drug, but they still do it. Yeah. Okay.
I mean, here we are, IV acetaminophen, Tylenol is very expensive. So that's a bigger expense for us compared to dexmedetomidine. You would not believe that. For some reason, how the pricing works in different parts of the world, it's
absolutely crazy.
It's so strange. There is another question for Dave, and that was from Dr. RK sir asking what is about the role of sternotomy in a mediastinal mass.
I think he was talking about an emergency situation. I think if there is emergency arises, say for example in MRI or CT scanner, and then you have to actually do that. And I think if you're not wrong, Dave did mention about that.
He did mention that.
Surgeons is there, always backup is there, isn't it?
Yeah.
Anyway,
again, I think it's okay to use it as a last ditch effort, but again, all this requires planning ahead of time. I probably will lean towards using ECMO before trying to do a sternotomy. But again, as I mentioned before, this all requires a lot of planning ahead of time and shouldn't be a last minute thing. But I would say call a friend, have an ENT surgeon available in the room for a rigid bronch, have the ECMO team on standby. And if you really are worried, you should be also calling your cardiac surgeon.
Yeah.
But at that time, I don't think it's safe to do it in MRI. It should probably be in the main operating room instead.
Yeah.
This may be actually the discussion were triggered by the fact that, say, for example, if you get a patient with, something like that in, A&E, adult patient, and they do crack open the chest in A&E. So, I mean, that's obviously like last ditch kind of thing.
Last ditch.
Yeah. So would not be the same situation in pediatrics. Probably easier to actually crack open the chest in kids than in adults.
I don't know. I find every time that trauma comes to the emerge, you would be surprised how long it takes to move that trauma to the operating room in a pediatric hospital. As the same trauma comes to the adult hospitals, in 3 minutes they would have already in the operating room. So it's nerve-wracking for the pediatric team to go to that step, which they haven't faced or done. So it's similar to we hesitate. We may try 5 times to intubate before you call it off and sort of go for a front of neck access, right? So it's just that you don't want to jump that step, and that delays the thing. And I guess I have never, in my last 13 years, I've never seen a trauma thoracotomy in our hospital. Whereas in adult gunshot injury, stab injury, and it's not an uncommon scenario, right?
Yeah, that's true. Yeah. Don't think there was any other questions. I can't see any.
That's great.
Anything else?
Again,
if others want to add?
Anything else?
Please download the PD Crisis app.
I have actually put it on the link on the YouTube as well, the chat. I'll put it up on the group as well, so that everybody can actually look at it. Yeah.
Like since we are talking about ECMO, just one point, like regarding eCPRs, not exactly with connected with the mediastinal tumors, but then since you're talking about ECMO and the EC, I thought in adult it's easier to do eCPR in the sense mainly the axis is usually the femoral artery and femoral vein, whereas in pediatrics it's usually the post-sternotomy, it is about the cardiac axis straight away in the right atrium and the aorta. Or if it is a little bigger kid, you could access either a carotid artery or a femoral vein, which is not so common, but it's usually the post sternotomy, the right atrium, which is for the venous axis, and aorta for the arterial axis. So with the CPR going on and you needing a sternotomy, it's not the best scenario. But in adults, it's easier to do because it's down below femoral artery and femoral vein, and you could continue your CPR. That's one point.
Yeah. That's true. I think in kids, everything is difficult. It's not the easiest kind of thing, isn't it? I mean, hats off to you guys dealing with small babies and children. I think I've not done pediatrics for a very long time, so yeah. But I think there's been lots of progress in pediatrics as well. Yeah.
To be honest, adults scare me. Children are way easier.
Not
I
really.
do not want to be doing an 80-year-old hip fracture. That will give me
that used to be till very recently. I mean, after COVID, I have not been dealing with fractures, but that used to be a bread and butter. On Wednesdays, I used to actually be doing from 8 a.m. to 8 p.m. Doing adults fracture hips and things like that. It didn't scare me at all. So I think in the end, it becomes what we actually do. I mean,
In fact, it's more difficult to do adults with so many comorbidities. Kids are very easier. Like pediatric cardiac, it's even more easy. You just have to worry about cardiac lesions.
It's an interesting perspective because I think how you actually train, and that's what actually. So because I do vascular as well, and a lot of orthopedics, and vascular is equally bad.
Yeah.
And these patients actually have lots of comorbidities similar to what elderly patients, and our population is actually getting older as well, what we deal with.
And pediatric surgeons are way nicer to work with than adult surgeons, so that's another plus for going choosing pediatrics.
That's nice to know. Luckily, I don't do any cardiac. It's only vascular. So here, vascular is actually separate kind of specialty. We have big. Ours is actually a regional center for vascular. So we don't deal with cardiac. But cardiac surgeons are all right here too. It's all. Yeah. But there'll always be personalities. But I think pediatrics as such. I think I loved actually doing pediatrics. I think pediatrics is challenging, and then I think this kind of apps which weren't there during our time, are very useful to actually be able to just put in the weight and age and actually get lots of data which is more accurate than sometimes making mistakes in calculations. I think drug errors can still happen in calculations. So I think that's one of the challenges in pediatrics, which is, I don't know if you actually heard about, there's called a Justin Foundation. And that reminds me because of the drug doses which Pauline actually mentioned. And in that case, Justin was just 11 years old when he went for a simple foot surgery. And he never came out. And later on, his mother, who is actually a big advocate now for safety in pediatrics, she is in, I think, New York or Jersey. And she's got a big, I think, foundation based on, it's called Justin Hope. You can actually Google it. And in that case, I think it was a wrong dose of vasopressor used intraoperatively where the blood was shot and he had a pulmonary hemorrhage and died. So I think drugs, I think we have to be very, very careful what we actually mention, especially when we are putting on the screen that we check and recheck at least the doses. People don't get it wrong.
So one thing I would like to know, actually, the algorithm or the guidelines of 2020, there is no mention about how long the CPR should be continued. Like in pediatrics, especially, I think terminating the CPR is an important decision. So there are no criteria given on how long to wait for return of circulation, spontaneous circulation. Like in babies who don't revive at all.
And the challenge is also what is the neurological outcome after 30 to 45 minutes of CPR. and the morbidity it carries both on families, especially in a healthcare setting where it falls on the family to take care of these kids. On further post-resuscitation care is also the prolonged ICU care, prolonged rehabilitation, and poor neurological outcome. It's going to be extremely challenging, and it's sort of a ethical challenges as well. You know, like what would be acceptable here, or whether sometimes the parents may not even have a say here. And the medical professionals will say that it's a 20 minutes downtime, we should put it on eCPR and cool the baby for 3 days and let the baby do some neuroprognostication scans and see how things go. Whereas in a poor healthcare setting, as well as how do you even engage this conversation? It's very, very challenging. Yeah, I honestly, I mean, obviously kids have a better survival and better neurological outcome even after prolonged CPR, especially on a very reversible causes. But it's, yeah, it should be a collective decision with the ICU pediatric team involved, as well as with the parents.
Parents,
yeah. Dave or Vikram, any thoughts around that?
You already spoken about the eCPR, but then like we usually take a time around 45 minutes, and if till 45 minutes, if there is not a shockable rhythm even once, like a fistula or a pulsal electrical activity, then we start thinking about calling it off, in the sense, and not trying for eCPR or anything like that, because if there's no shockable rhythm, then it's no point going ahead and doing something for us. Right?
Excellent, guys. I think it's a good time to actually, I think, end the symposium.
Yeah.
It's been a pleasure actually listening to all the talks and all the discussions. I'm sure everybody got benefited by the symposium.
Yeah.
And I hope to see you all soon.
Thank you. Thanks, Shiv. And I would want to thank every panelist. It's a great day.
Thank you.
Bye. Bye.
Thanks.